Hello, everyone. I'm Shanta Jackson, the Chief Executive of Cause Engagement Associates and the author of the Journal of a Woman with Lived Experiences. And thank you for joining me today for this live, unedited, uncut, unfiltered conversation with three phenomenal women who are all public health practitioners located in Las Vegas, Nevada. Joining me, I have Dr. Melva Thompson-Robinson. She is full professor at the School of Public Health at the University of Nevada, Las Vegas, and she is also the director of the Center of Health Disparities Research, also located in the School of Public Health at the University of Nevada, Las Vegas. And Melva, your journal, I forgot the name of the journal, but I know you have an internationally known journal. Could you please?
Yes, it's the Journal of Health Disparities Research and Practice.
Perfect, thank you. And then also joining me is the public health pharmacist, the award-winning public health pharmacist who has been a major media contributor to this regarding COVID-19. And she is also an associate professor of pharmacy practice at Roseman University of Health Sciences in Las Vegas, Nevada. And she's a public health consultant, and she has two clinical practices, one at the help me out, Christina.
Huntridge Family Clinic, where we cater to the LGBTQ community, and Volunteers in Medicine, where I do communicable disease and immunization services.
Perfect. And then I also have with me Elisa Howard. Miss Elisa Howard is an eight-year public health educator. She's also a community health worker instructor, and she is the owner of a public health firm, I'm sorry, say it again.
Minority Health Consultants.
Minority Health Consultants. So what happened was I was trying to remember all of that in my head, and I'm not reading from anything. So Minority Health Consultants. And thank you, Elisa, for joining me. Melva and Christina, is okay if we're on the first name basis?
Yes. Absolutely.
And so for today's conversation, I wanted to, the name of the show, the title of the show is Public Health 911. And the reason I decided to use that title is because I'm monitoring and I'm paying attention to the what's going on in various communities, the news, and then also social media, and the different perceptions that people have about the government, about public health, of COVID-19, vaccines, health disparities in general, mistrust, racism, and not just in a social justice aspect, but also in public health and healthcare. And so I felt that I felt kind of obligated to have a conversation, and I was thinking about, who do I know or who are like-minded, but that have different perspectives, and we can bring in different sources of information. And so thank you all for joining me today. And I guess I'll start with Melva, and we'll talk about the role of public health in our society. Could you inform the audience? So our audience is a mixed audience. We have majority of individuals who are not in the field of public health and who are not familiar. So just keep that in mind. But Melva, the role of public health in our society.
So public health is concerned with several different things. One is disease prevention. So how do we stop diseases, whether it's COVID-19 or whether it's heart disease or anything else? Like, how do we stop it from spreading in a community? How do we stop people from getting infected or affected by the disease of interest? We're also looking at it too from the perspective of trying to understand who has the disease. So this is kind of where the epidemiology comes in. So, when people are talking about the numbers of people who have COVID and who has COVID, that's where that piece comes in. We also are concerned about environmental health. So, what's going on in the physical environment, what's going on with air quality, et cetera. Public health also relates to a point, healthcare. So how do we manage healthcare systems, or how do we manage public health services so that we're meeting the needs of the community? So really, public health is really centered around the community, around population, around people, and making sure that groups of people, and in doing so, making sure that individuals have good health status.
Okay. And Elisa, do you have anything to add as it relates to the role of public health in society, or even more, maybe the role of community health workers in public health?
So yeah, I think Melva did a great job explaining public health for lay people who don't understand what public health is. I think a lot of the community and population of people are starting to understand it a lot more because of COVID. They're probably hearing the word public health more than they ever have. So I'm having to not explain my job as much as I used to, which is a great thing. But community health workers, I've been saying from the very beginning that they should be implemented from the very beginning of this. This is what they were trained for. So at CSN, we've trained over 500 community health workers. And I know in the North, for the state of Nevada, they've trained over 500. So there's about 1,000 community health workers spread out through Nevada. And their whole goal is, these are people from the community. These are people that we brought in from their particular community. They have cultural competence already. They know their community. They are the people that their neighbors go to for answers, for resources. They may just be the neighborhood taco lady. They may just be the neighborhood candy lady like we used to have in the Black community, but they know things. They know people, right? They're connected. And so when they get resources, they spread it out throughout the community, including education. So we brought these people in and we train them to understand public health and to have a role in public health. And so that's why they're the best thing that we could utilize right now. They also save states hundreds of thousands of dollars because of the fact that they're coming from the community. They don't have to go get a bachelor's degree or a master's, not to say that they should not, but they're coming in with a high school diploma with knowledge already that sometimes some people have to learn and take years to learn. So I just think they're very instrumental in this time, and I think we definitely should be using them.
Okay. And Christina, what is the role of a public health pharmacist?
Yeah, so great question. And I just also want to echo Melva and Elisa's points that, public health is really about the health of the many versus the health of the one. So I always tell my students that, when we treat one person's disease state, like diabetes, it helps that one person and it impacts that one person. But when we start looking at the population as a whole and how we can decrease disease prevention or do preventative care within our population, that's what really makes the biggest impact. So we always want to make sure that we're thinking about the health of the many versus just the health of the one. And so for me as a pharmacist, I think initially when I first took my position working with the public health department now, oh goodness, this was like 13 years ago, when I first started working at Roseman, they had never had a pharmacist before. I had never worked specifically in public health before, but I did have a background in infectious disease, and I knew that I wanted to do direct patient care. And so, that decade that I had working at the health department, I can't even explain to you the value of that and how much I learned about just my community and how I could be most impactful in my community. And so I think traditionally, when you think about pharmacists, you don't think about them specifically working in public health, but ultimately as one of the most accessible healthcare professionals, we are engaging in public health daily, right? We're counseling people on their contraceptive options, which is family planning. We're helping people with STD prevention by, doing harm reduction strategies, making sure that they know where they can seek, condoms. California just implemented, the SB 159, which allows pharmacists to furnish HIV prevention without a prescription. Colorado just implemented and signed their legislation, and they have about 6 months before they're going to implement that HIV prevention strategy through pharmacist intervention in their state. So, there are many things that pharmacists can do that are specifically public health, and especially now, even more than ever with COVID-19, the federal government allowing for pharmacists to not only conduct COVID-19 testing, but to order COVID-19 testing. So we have a lot of pharmacists out there that want to engage in these what I would consider more advanced clinical services, but we are not doing enough to really empower them to feel like they can help in these times of need. I think traditionally you may think about them doing vaccinations, which is very much a public health intervention. It's actually one of the most effective known public health interventions that we have in modern history. And unfortunately, we are seeing a lot of resistance to things like vaccinations, and those same quote unquote anti-vaxxers are what I'm seeing now with the anti-masking campaigns, where people are thinking that this is infringing on their, you know, their liberties and their freedoms, when really all it is that, you know, I wear a mask to protect you from me, you wear a mask to protect me from you, and it's a respect thing. And, you know, we all have to do our part to make sure that we're protecting our community. So to roundabout answer your question, what is a public health pharmacist? A public health pharmacist is a pharmacist that engages in community by preventing disease and informing the public about how they can reduce their risk for chronic medical conditions as well as communicable infectious diseases.
Okay, thank you for that. So ladies, Christina just mentioned, I heard in my mind, I'm thinking stigma, mistrust, especially as it relates to vaccines. But just so we kind of went in naturally to talk about COVID-19, but before COVID-19 and in addition to COVID-19, what are some of the health disparities that are plaguing, in particular, the Black and African American community in Las Vegas or in Southern Nevada in general? And then, so I would like for Melva and Elisa to answer that, but then also, if Christina, if you can follow up and maybe give us your perspective as it relates to the LGBT community.
So I would say, unfortunately, probably, excuse me. So when we're talking about health disparities, we're talking about differences in health status. And usually those differences, we're looking along the lines of race, ethnicity, but we could be looking at gender or sexual orientation. And so when you're looking at these in Southern Nevada in particular, but really across the country, African Americans, for the most part, have a poor health status than all populations. Whether you're talking about HIV, you're talking about hypertension, cancer, so on and so forth. So it's really kind of a dire situation. One of the things that I want us to keep in mind, particularly about cancer, but it also plays out when you hear people talking about hypertension as a silent killer, is that oftentimes African Americans don't have, for example, cancer at higher rates. What's happening is African Americans are being screened later, and therefore when they are diagnosed at a later stage, which is then resulting in them dying sooner and faster and more often. And the same thing, you know, like if we're talking about stroke, you know, hypertension is one of those things that, you know, a lot of African Americans and a lot of people in general don't know that they have. And when they do find out they have it, usually it's the result of a stroke or death or some other issue that's really causing a significant problem. And so, you know, when we're looking at this, we have to understand not only is it, you know, that their number of cases may not be the same, but then why are they dying from these diseases when other populations aren't dying as rapidly? And so, you know, not that it's ever really a competition about who has the worst health status, but honestly, between African Americans and Native Americans, our health status tends to be among the worst. And this is whether you're talking about COVID-19, you're talking about cancer, or other issues and diseases.
Okay.
I pretty much mimic what Melva said. I think the question is, where are we not in the worst category? Unfortunately, that's what we have to look at. I work on so many different projects, and they're all involving African American communities, from hypertension to HIV to diabetes. And these are all companies that have a focus on helping us, right, with intervention or early intervention. And I think that's one of America's biggest problems, is that we are an early intervention type of country. We're not a prevention country. And I'm a prevention person because I believe in preventing a disease before it even happens. But like Melva said, it's pretty much we have health disparities, right? Because of the health access to getting appropriate, accurate cultural information. I had a friend call me the other day that said that a contact tracer told them that they had COVID and got off the phone. Why is that happening? Are people not being trained accurately? He didn't know who else to call. What else should he do? Was he going to die? These are things that I'm seeing happening to people of color. I don't hear the same conversations with my friends of other races. So it just makes you believe like something else is going on. Either they're not culturally competent or they're not educated in how to provide that education. So there's just so many facets of things that we could talk about of what's going wrong. But I really think that prevention is definitely one of those things that we do not focus on enough. I hear a lot of people say, we don't get funded for prevention. That's one of the main things. We don't have money for prevention. Okay, so that just shows you where the country's efforts are. And that's really one of the main problems, because African Americans, because we are predisposed to a lot of things, we need prevention a lot more than we need intervention. We need both, but prevention needs to be there as well.
You know, I wouldn't necessarily say that we're predisposed to a lot of things. I would say because we aren't getting care, preventative care early on. So we aren't going for our annual physicals. Mm-hmm. Things that could have been stopped early on aren't being stopped early on, and therefore getting out of control. And that's where we end up with our problems. If, you know, issues had been taken care of early on, we might not have some of these things. So, you know, if people are getting hypertension and they're getting in and they're being seen, then they are doing that and they're able to prevent a lot of things from happening. So, you know, the genetic predisposition for certain things really just doesn't exist unless it's something that runs specifically in your family.
And that's what I was speaking of, hypertension, things of that nature that are already running your family, from your mother, from your father. A lot of people, like I work on the hypertension project, and we screen a lot of people. And one of the first questions is, does someone in your family have it, your mother, your father? And they all always say yes. And so they're very shocked when they find out that their blood pressure is high. So just things like of that, that's what I was really referring to.
Yeah, so family health history, it's very important for everyone who's out there listening. And I know this year we did not have the opportunity to have our family reunions as planned, but that's an activity when you're thinking when you're on your family reunion planning committee. One activity that can be done is to actually go online and find some resources for a 1 or 2 page document, and to give to people as a resource to start jotting down family health history. So, for example, my brothers, my sisters, my mom, my mom, my dad, my paternal grandparents, maternal grandparents, and so forth. And then you might start seeing a pattern. And if you see that pattern, then that's an indication that it's time to go to the doctor and then inform your doctor of your health history. And if you currently have, so for example, if you have cancer, let's say prostate cancer, my father was diagnosed with prostate cancer. So my son, his grandson will have to be screened a little sooner because he has a family health history of it. Versus the traditional age, which I believe I can't. It blanks my mind right now.
50.
Is it 50 for prostate? Yeah, 50 for prostate. 50. And so my son, I would encourage him to get screened at age 40, at least 10 years earlier. Dr. Matt or Christina, tell me a little bit about some of the health disparities facing the LGBT community nationally, and then you can make it focus on more locally in Southern Nevada.
Yeah, so I feel like the first and foremost thing that I would say is it's all about access to care, right? And so just to kind of echo the points from, Melva and Elisa, when we look at the disparities of health, the issue here is that a lot of times there's a lack of access, right? So access. So when you lack that access to care, or you fear the traditional healthcare system, which we see a lot in the LGBTQ community, it's going to make you put things off that you wouldn't ordinarily put off because you either mistrust the healthcare system, or in the case of African Americans, we have a lot of historical trauma. I mean, just think about Tuskegee, when we start talking about STDs and HIV. And then ultimately, when you don't see someone who looks like you and talks like you, right, from a community health standpoint, that's why community health workers are so important, then you're less likely to engage in those preventative care measures and follow up with your healthcare needs. And so if you don't already think about that being at the top of your mind as being a need, then you're less likely to get those interventions. So when we think about the LGBTQ community in specifics, they're more likely to have issues with substance use. They're more likely to smoke. They're more likely to have challenges with sexual health, so HIV and STIs. They are more likely to suffer from anxiety and depression. They're also more likely to have suicidal ideations and attempts, and unfortunately, those attempts are typically successful. And part of that is because of the lack of peer support, or if they do, engage in talking about their authentic selves, not getting that support from their families, or if they do come out to friends and family, they feel like they may be judged or they may be stigmatized. And so specifically here in Southern Nevada, we have been targeting the HIV prevention side because we are designated as one of those 48 counties that has been identified by the Centers for Disease Control and Prevention as having the possibility of having an outbreak of new HIV transmissions. And those new HIV transmissions have been in individuals who are younger, so under the age of 25. And then those who are sexual and gender minorities are unfortunately disproportionately impacted. And then when we start thinking about communities of color, if you contrast an African American men who have sex with men, they have a 1 in 2 chance of getting HIV in their lifetime, versus a Caucasian female, they have a 1 in 882 chance of getting HIV in their lifetime. So, I mean, that disparity is just, that's a chasm of, just cataclysmic, proportion. How do we overcome that if we're not out in the community talking about why HIV prevention is important, why having that peer support and having that localized conversation where we're bringing up that dialogue about safe sex practices, harm reduction strategies. And if it's not coming from somebody who looks and sounds like them, they're less likely to be engaged in those interventions. And so I think there's a lot of, parallels between, disparities within the African American and persons of color, as well as in the LGBTQ community, because a lot of times they intersect, because we have those individuals who are sexual and gender minorities who are also, of an ethnic background. And so I feel like as an African American woman, I have a duty to be out there and to be discussing these things on a regular basis. And really, one of the things I love about my clinic is that we are so sex positive, and that we talk about, it's not just about who you are and who you love, but it is also where you live. Because my risk living here in Southern Nevada is different than somebody who lives in rural Iowa, right? And so you have to know about all those factors. But if you don't even know enough to know that you're at risk, how do you even start? So I'm hopeful that, obviously you ladies are so impactful in our community, but it takes those little steps to really bring these things to the forefront, and getting the information out there. And that's why I feel very fortunate to have this new platform, because I have been doing so much media lately, because at the beginning of this pandemic, there was this rumor that African Americans couldn't get COVID. And I truly feel that the reason why we're seeing so much disparity and so much difference in the rates of deaths is because of that initial messaging that was coming out and people not thinking that they're at risk.
Okay. And this question is for you, Christina. As a clinical practitioner, both Melva and Elisa mentioned access to care.
Yes.
So access is one issue, but then there is quality care, and then Elisa, you mentioned already culturally responsive and culturally competent care. What advice would you give to other clinical practitioners when they, and I'm thinking particularly again with LGBTQ, when they see a patient for the first time and they walk in? What is an icebreaker, or what is a practice? And this doesn't even have to be for clinical practitioners, but then also for counselors, therapists, social workers in general. What is something that they can, from the very beginning, do to make someone feel comfortable, to where they're in a non-judgmental space where they feel comfortable talking about their health history and receiving health services from that individual?
I feel like the first and foremost thing, and I actually have this on my signature line, is what my pronouns are. And I know that sounds like it's a very simple thing, but the terminology and being on the same playing field and talking with somebody, asking them what their preferred name is, I typically will start off with saying, my preferred pronouns are she, her, and hers. How would you like to be referred to? Obviously, that's more of a thing with our individuals who are living a trans experience. But I think in general, in our sexual and gender minority community, that's a good way to kind of start the conversation, especially because we have individuals who don't identify with either gender, who are either non-binary or gender non-conforming. And so
what is non-binary and gender non-conforming? What does that mean?
Yeah, so when we think about gender, so thank you very much for making sure that I bring it down to like the basics here. I'm in this space, and so I talk like this all the time, so I apologize. So those who are gender non-conforming or non-binary, all that means is that they don't identify necessarily with either the being in the feminine space or in the masculine space. They choose to or feel as if their authentic selves doesn't really identify with either, and so they consider themselves to be non-binary, or I've also heard the term genderqueer. So some days they may identify more in the masculine space, and some days they may identify more in the feminine space, and that's okay, because I really look at gender as being very fluid, and because there, especially with this current generation, I feel like there's a lot more attention being paid to both sexual orientation and gender identity. And so knowing that those things could be fluid and not having a defined, regimented thought process when we think about the construct of gender, I think is a great opener when we're talking about sexual orientation and gender minorities.
So I just want to piggyback on that, because I think the respect piece is huge. It's huge, regardless of who you're dealing with, So, you guys have known me for a long time, and I'm not always Dr. Thompson-Robinson, and when I show up places, I'm not, dressed like what people would think of a typical professor and things like that. And so I get treated some ways that normal people get treated. And I'm like, that's not right. That's not appropriate. You need to treat me with more respect. I'm older than I look, and if I feel like I'm old enough to be your mother, then don't be treating me like, hey, that's not going to work. You got to treat people with respect, regardless of who they are and how they identify. And that's where we start first, before moving into some of these other things. Because if you ain't treating anybody with respect, you're not going to treat everybody with respect. And it needs to start there.
Okay. let's talk about trust. We have these various organizations, institutions of higher education. We have these hospitals, public health departments, who, as you all explained, rightfully so, would want to, they have intention of providing services to disparate populations, whether it's Latinx, African American, millennials, whatever the risk of the population or the community or the group that they want to serve, right? But at what is the role and responsibility of these institutions when you're going into communities? What should they do before entering into these communities to offer some type of service or health intervention? And then, and when engaging and working with these communities, what level of involvement, in your opinion, do you think that community members or community leaders should have in decision making, and then also even just sharing information?
So I don't know if you do this with your students, Melva, but I've started implementing implicit bias training with all my students. So I feel like you got to start even just from there and understanding what your own internal biases are before you can offer culturally competent care. And so and that's something that I've started implementing with all of my students on rotation. I have them take some other courses on LGBTQ care as well. But I feel like that implicit bias and knowing what your own internal biases are is so important, because a lot of times people don't even realize that they have those biases until they're brought to their attention. And so I feel like that even just has to be like first and foremost before we can even get into the culturally competent care. And then, you know, the backs of our modern day, you know, healthcare system are built on, you know, things that were done to, you know, our African American slaves, right? So the modern OBGYN practices was built on experiments on African American women and slaves. And, you know, the thought process that African Americans don't experience pain at the same level. And, you know, all of these biases that are inaccurate, by the way, unfortunately, are pervasive in our healthcare system. And so we need to identify those biases so that we can start overcoming them.
Okay. So I have a couple of things. I actually wrote down trust from what you said earlier, Shanta. You talked about family reunions and possibly bringing some information to our family reunions. One, I think that's a great idea. I will have to do that next year in Houston. And secondly, it made me think of when I did go to my parents and ask them about their family history as far as health was concerned. My father, so we have to think about the generations that we're talking about, right? My father said, don't worry about that. You live your life, eat as healthy as you can, be as healthy as you can, and you let them tell you when you have something. And I was just like, what? And it was like, why can't you tell me what you have? Why can't you tell me what your father had, what your mother died of? And he felt like it wasn't his business to tell me that of theirs. And I thought that was a very interesting perspective, because I actually told him, I said, Dad, you know, this is what I do. And that idea and that ideology is basically why we are the way that we are as African Americans. This whole keep my business to myself keeps us really unhealthy, right? If we don't know our family history. So I thought about that, and, you know, I go back to him like in pieces. So like, I'll just ask one question instead of like bringing it all on him. And I'm getting some information, but it's like, good Lord. So that goes back to trust, right? It goes back to family trust, but it goes back to just trust of the healthcare system. So he said, you know, don't let these doctors tell you that you have all these things. You get second opinions and things of that nature. And I'm just like, okay. So it just really opened my eyes to how just within my own family, you have to break down some of those structures and some of that non-trust issues. But also from a community level, I think leaders need to go in transparent and honest. And I think people who are not in the community need to stop saying they are in the community, because our community is one that will call you out. Our community is one that says, we don't know you. You've never been here. You can call yourself a community leader all day long, but I've never seen you. I've never seen you at the MLK Senior Center. I've never seen you at Doolittle. I've never seen you at the what is it, Juneteenth fair. I've never seen you. So stop calling yourself a community leader because I don't know you. Whose community are you leading? So I think we need to become very clear and transparent about that, and possibly call ourselves other names if we're not really working directly with the community.
Okay. And Melva, if you can respond, and then I have a question from Andre Wade for you.
Okay. So, I mean, so trust is a lot of different things. And so part of it is, you know, in thinking about trust, we have to remember, particularly, you know, like I see my mother's on, and so I'll use her as an example. You know, she grew up in Jim Crow, South Carolina. And in that meant that when she went to, if they went to the doctors, they were often seen last. They may have been told things that they didn't know were true or not. So as a result, that's not the first thing we do. Okay. So even, you know, and I too am a child of the South, you know, that's not the first thing that we do. My kids will tell you, like, other than going to the doctor for an annual physical, and even when it got to a certain point, that kind of stopped, you know, we didn't quite do that. And so the trust is really huge. And part of that comes from where we all come from and where our families have come from and what we've endured and the experiences that we've had or that others have had as a result of, you know, being African American. But trust also comes from when we don't see people who look like us who are providing services. We don't see people who look like us who are speaking about, here are the issues in our communities. Okay, that then becomes a real challenge because people go, well, how do they know? We never, like Elisa said, we don't see them, we don't know them. And so as a provider, as a researcher, as someone who works with communities and works in communities, I'm always brought back to some words of my Native American colleagues where they were like, we don't want people doing safari research in our communities. And I said, safari research. And they said, yeah, you know, like when people go on safaris and they go to Africa and they're like, oh, look, tiger, and they take a picture. Ooh, elephant, and they take a picture. And then they go off with their pictures and they never come back. Okay. We can't do that same thing in communities. We can't come in and get our data and then leave and never come back. You know, we can't come in and say, oh yeah, they are sick. They do have poor health status. Too bad for you, and go on about our business. You know, we have to, if we're going to work with communities, we've got to be embedded with communities. If we are going to work with communities, it's not a I know more than you know. Okay, this has to be a knowledge partnership because there's things about the community that I don't know, but there's things about public health that they don't know, and we can learn from each other. Okay, I always tell people I am not a creative person at all. Although sometimes I have a moment, but I'm really not creative. A lot of my ideas, as it comes to projects, as it comes to things to work on, are not always taken from me looking at the literature. It's taken from me talking to community people and finding out what are your issues and concerns, and let me think about what we can do about it. So I think that's the piece, you know, when you want to figure out how to handle the mistrust, it's got to be, you know, on these things as well, and understanding how we go from there.
Yes. So for those of you watching that don't know, Melva is my former professor, and what you were just saying. And so I graduated with my master's in public health in 2010. But I remember in your class, we were talking about, I believe it was a pre-seed proceed, which is a public health planning model. And when it comes to conducting needs assessments, you're also looking at the strengths of the individuals that you're looking to work with, and but also you're letting them define what quality of life means to them. Sometimes we say people should live this way, and this is how your home should be, and this is the exact food you should eat, and certain things, or this is how your life trajectory should be, and your education, or different things like that. But we have to meet people where they're at, and not for us to put what we deem is a good life on them. And so I think that's a lens that I would encourage researchers and other public health practitioners to have, as well as healthcare. And also, for those who are watching, there's a difference between public health and healthcare. As when Melva, when she first started with the first question, I was asking about the role of public health in society. And so just a recap for those of you who are just joining in. Healthcare focuses on the individual. Public health focuses on communities, populations, groups of individuals, not or groups, should I say, not just the individual person. And usually, healthcare is reactionary. And so, in public health, there are these three different levels of prevention. So you have primary prevention, secondary, and what we call on the third level is tertiary. And so usually and anyone chime in at any time, which usually with tertiary, it's we're trying to pretty much comfort you and prevent death. You've already been diagnosed with the disease. So for example, you could be diagnosed with stage 3 or stage 4 of cancer. That's more so the tertiary stage. The primary prevention stage would be the screenings, and then secondary. How would you explain secondary, Melva?
So I like to explain it like this.
Okay.
So we think about mammography, right, and women getting a mammogram. And when you talk about primary prevention, you're talking about just that annual screening. So everybody gets an annual mammogram to see kind of what's going on. That's, you have no signs or symptoms. Secondary prevention is that you now have a lump. So now the reason that you're getting the mammogram is to see what's going on with the lump. Okay. Tertiary prevention then is now a woman has breast cancer. Okay. So now she's either gone through some type of treatment, or we're trying to see exactly where it is so that we can prevent death. So it's always a mammogram that she's getting. It's the reasons why she's getting them, whether it's screening, whether it's because she has symptoms, or as a part of recovery, is the difference between those types of prevention. So I always tell my students, like, don't think that you're going to use the same message for the same reason, okay? Because it's still the same behavior, but it's always going to be a different message based on the reasons, primary, secondary, tertiary prevention, that someone needs to get a mammogram.
Okay. And Melva, I have a question for you from Andre Wade, and he would like for you to speak on the need for better data to look at the Black community from an intersectional lens.
Right. So, so I talked about, like the epi data. So looking at the data to see who has the disease, what are their characteristics, why do they have it, so on and so forth. Well, if you just look at data by race, so you just look at the Blacks, for example, or you just look at age. So now you can say people 18 to 24, or people 75 and older, or you just look at women, or you just look at men, you miss a lot of things. And you can't say, so if you just look at Blacks, if you just look at women, and you just look at people 18 to 24, you can't look across those and say, oh, well, it's Black women 18 to 24 who are most at risk for this health problem. You have to look at the intersections of those data. So you have to look at race, look at gender, and look at age and maybe other factors together as an intersection to see kind of what's actually going on with a particular population. Just to say, for example, the Blacks have the problem really doesn't get at the diversity of the Black population in terms of gender, in terms of age, and things like that. So things that you might do, call yourself doing for a Black population aren't going to reach everybody. And to a point, Black women will go, well, I don't think that's about me. That's really about Black men. And Black men are going to say the same thing. And then the LGBTQ are going to be like, well, you ain't talking to us anyway, so it ain't about us. So, we've really got to look at these intersections. And part of the reason, it's something that I've been saying a lot lately, is when you do that, you can better tailor your interventions. And in that case, the federal government and other funding agencies fund based on being able to implement the intervention. There's no interventions that are out there just for the Blacks, okay? There's interventions out there for African American women of childbearing age, which is 18 to 45. Although, if you're over 40 trying to have a baby, good luck with that.
That's mean. I'm 39, and I'm undecided if I'm going to have more. But tomorrow, my son will be 16.
And he might be like, Mom.
Right. Don't do that.
So I'm just saying, hey,
traditionally, African American women are fertile longer.
Right. But I mean, you don't know that if you aren't looking at those intersections. If you're just looking at age, you're just saying, 18 to 45 is when women have babies, So that's very important. And again, because funding agencies are funding based on interventions that are based on these intersections, if you don't have the data to support that or to make a case for why your, this particular population needs to be targeted, then you lose out on the money. So, and that's a real problem.
Okay, and we've pretty much touched all bases and all points. We do have some additional questions from YouTube, but we may not be able to get to them. However, one thing that we haven't talked about, so we talked about, and I think this is a good segue. We talked about mistrust, and we're talking about data from the question from Andre Wade. But what about research participation? Why is it important for individuals, particularly people of color and LGBTQ, to participate in social and behavioral research, which could be interviews, focus groups, surveys, or maybe even clinical research? Why is it important, and how does that impact community health? Any Christina, and then
I was going to say, who wants to go first?
Yeah, I mean, it's hugely important. I mean, I'll just tell you from the aspect of HIV care, because that's a lot of what I do, obviously with my work, and I'm credentialed with the Academy of HIV Medicine. And so, especially in our individuals of trans experience, they have often been left out of some of our research models. And so, it's even more now imperative than ever when we start looking at the differences between, if somebody is engaging in gender affirming care, how does that impact if they're on HIV prevention or HIV treatment? And so it's imperative that we have, more representation within studies, because otherwise we're not going to know, if there are differences within those populations, and should we be changing our interventions in order to meet those criteria. And to go back to, to Melva's point before about that intersectionality, and how do we manage that if we don't have the data to support it? And the only way we're going to be able to do that is if we get participation in things like, population research, but really clinical research as well. And so, we see that a lot in HIV studies is that it is unfortunately predominantly in Caucasian men. And so it's a big effort from the pharmaceutical industry, because obviously I'm a pharmacist. I know that they are trying to engage in participation from persons of color, as well as those that identify in the LGBTQ space, and then our sexual and gender minorities and our individuals of trans experience. But it's a challenge. And again, I even want to bring it back down to just the fact that we don't have providers that look like these people, right? And so if we're not engaging in having more persons of color being doctors, nurse practitioners, pharmacists, we're not going to get engagement unless people see people who look like them. So we got to start off even with the allied health professional education strategy. And we need to look at, why medical schools are still only accepting, 2, 3, maybe 5% of their medical school class is African American or, persons of color. We need to address that. And until we address that, it's going to even be even more harder for us to engage in some of these, interventions, because it goes back to trust. If you don't look like me, you don't sound like me, how can I trust that what you say is true? Because we have historical, institutionalized, entrenched racism throughout our entire society. And we need to think about that before we start saying, oh, well, we need more people from this population or this population. You're not going to get that way until you address these underlying seated, entrenched issues.
Right. So, yeah. Kind of back to the education piece. So at UNLV, I always lose count. There's like 4 or 5 African American women who are full professors with tenure. Okay, so we are at the same rank as far as the food chain for faculty goes. We're at the top of the food chain, 4 or 5 across an entire campus. That's not cool. And we can talk a whole bunch about that. But when students come in and that's not who they're seeing, or they come in and I'm the most educated African American that they've ever seen, that's a problem. Okay. But that happens a lot, even with my graduate students. Okay. So that's kind of the one piece of it. But, again, going back to the safari research, kind of making sure that we aren't doing that safari research, that we're giving back to our communities, that we're there. Understand that when we do that as researchers, that puts a tremendous burden on us, because we're in this whole publish or perish mode where we've got to publish, we've got to get grants, we've got to do all of these things. So in some cases, the research that we're doing isn't always valued because it's, oh, well, it's those people over there and, they're a small portion of the population. And then when I have to go back now into the community and say, this is what, then that takes away my, some of my time as well. All that means for me is that means my plate is fuller. Like I tell people, I'm, like the person in the circus that's got the sticks and they're spinning plates. That's what I do. But the participation in the research is important. One, because not only does it support me and other people who look like me when we're there, but we have to tell our story. We have to tell our own story of what's going on in our communities, and we need to have that voice. We need to be involved in the research and telling that. The other piece is that when you talk about the clinical side of it, okay, drugs, vaccines, other kinds of medical treatment, even artificial intelligence are coming out daily that don't look like people, that don't reflect people like us because we didn't participate. And so there's always that possibility that those things aren't going to work for us because we do things a little bit different. Okay. So we have to be involved. But I get it. Trust me, I get it because I struggle every day. I get asked by people, oh, help us recruit African Americans into clinical trials. And while I want to, because I understand why we need to be there, my concern also is if someone has a bad experience, that comes back on me. And a bad experience can be anything from they were treated poorly to an allergic reaction to death. Okay. And I don't know if I personally want to be in that space.
Your black card might be taken, Melva.
Huh?
Your black card might get taken from the community, Melva.
Right. I mean, it might be it. I mean that, but it's just, and I don't know if I personally could live with myself, you know? And so, like, even though I'm asked all the time about, you know, helping with clinical trials, I really have that struggle. And even now with, you know, with COVID-19 and talking about people getting into clinical trials for the vaccine, you know, the first thing that comes to my mind is, am I going to have a reaction, and what is that going to be, and can I deal with that, you know? And, you know, like, look, I'd have took my researcher hat off, I'd have thrown that down, and I'm thinking now, me as a Black person, and as a mom, and as a this and a that, can I deal with all of this? And so I get the scariness, but I also understand we've got to somehow figure out how we can be involved, how we can trust the medical establishment, you know, because, you know, again, not to keep going back to Tuskegee, but Tuskegee really was a study about men who had syphilis. And during this time, they discovered penicillin worked in terms of stopping their infections. And these men were not given penicillin. These men passed syphilis on to their wives, to their children, to their communities. Okay? That's heartbreaking for me personally, because I'm like, how can you do that to somebody? How can you watch that? You know, I think about the movie Miss Everly's Boys. You know, she's the one that made the Tuskegee syphilis study successful. Okay, it wasn't the U.S. Public Health Service. It was this nurse who knew where these men were and could go find them in the fields or on the street corner, wherever, in church, and keep them in the studies. I don't want to be that. I can't be that. Okay. And this is me speaking. This ain't Dr. TR or anything like that. This is me speaking. I don't want to be that. So that's a daily struggle I deal with every day, thinking about vaccine trials for COVID, thinking about a flu shot, thinking about getting people into clinical trials. How do we create a situation where everybody feels comfortable in doing this work? Because right now, everybody ain't comfortable and everybody ain't participating.
Yeah.
Really quickly. I'm sorry.
No, I'm sorry. It was an echo, and I was just trying to tell you about the echo. But I want you to close out with your statement. But then also, if you could please do respond to Melva and Christina, but also for individuals who are interested in becoming a community health worker, how can they do that?
Okay. So to respond to Christina and Melva, education equity, even I'm seeing it even with the community health workers. There's only about 2 to 3 Black students who come to the community health worker class, when there's more African Americans in the community than just 2 to 3. So if you're getting 2 to 3 out of a 15 participant class, are we really being effective even in that area? So education equity is one thing that I'm really big about as well. Melva talked about only having 4 to 5 professors at UNLV. I didn't see that many at CSN when I went to an adjunct professor conference. When I did see one, it's the typical thing like, hey, hey girl. I see you. I see you. So that's one thing for sure. But the trust definitely has to come from us. And I'm getting the same questions as Melva's getting, because people know I work in the community. As a consultant, that's something that we have to think about as well. That's why I'm very big on integrity and working with stakeholders who have integrity, because of the fact that they will try to get you to do something or pull your community in on something when they may not have the best, they don't want to do what you would do for your community, right? So you have to figure out, talk to the stakeholder, what do you want to do with this information? What are you going to do afterwards? Are you going to just get this information, like Melva said, with the safari analogy? Are you just going to come in, take pictures, and leave, and not come back and do actual intervention, or bring us back some information on how we can be healthy? So that's one thing that I think as public health consultants that we really have to look at too, because we need money, right? We need to survive in this game, but also you don't want to sell your community out. So that's just one of the things that came to my mind as they were speaking. And then as far as community health workers, College of Southern Nevada offers the community health worker class. You can get in contact with luz.castro at csn.edu, or you can contact me, Elisa Howard, on Facebook, and I can connect you with her. But basically just let her know that you're interested in being a community health worker. The state of Nevada is offering grants. They've been offering grants for the last 3 to 4 years. Also, the state of Nevada offers an online program. And so they can go on the State of Nevada Community Health Worker Program, and they can sign up on there if they're not able to go to a physical class. Of course, with CSN, we're doing virtual classes right now. So I have my next one starting August 4th.
Perfect. Thank you. Thank you, ladies, for joining me. Thank you for dedicating your professional careers to, again, not just focus on the health of individuals, but the health of communities in whole. Thank you, everyone who joined us on Facebook and YouTube, and thank you for your comments. And I'll make sure that I include everyone's contact information in the comment section.
Absolutely.
Thank you. Thank you.
Thank you
for having me.